Rolika, can you see now?
Excuse me, doctor. We are live
Yes.
now.
Yes. Can you see my slides?
Yes, sir.
Yes, sir. Dr. Purva, your slides are seen.
Welcome to the third episode of Research Matrix. This is Rolika and Ayushi's brainchild and an initiative by YOSI from the research cell of the YOSI working group. So, without further ado, let me introduce today's topic. One second, please. Today, we are going to talk about the code of design. The debate is the morality matrix. The only way forward, randomized control trial is better than retrospective studies. Speaking for this statement is Dr. Rashmi Deshmukh and against is Dr. Prasanna Venkatesh Ramesh. And we have a star-studded panel with expert faculty like Namrata Sharma ma'am, Vivek Dave sir, and Ritika Makija ma'am. Let me introduce you all to them. Dr. Namrata Sharma needs no introduction. She is the chairperson scientific committee of AIOS, president of the Cornea Society of India. She's the first Dr. Paul Dubord awardee for international eye banking. She's featured in the top 2% scientists by the the Stanford list, which we all know in 2023. She's been the top 100 in the top 100 most influential ophthalmologists in 2022 by the Asia Pacific Journal of Ophthalmology. She has over 650 publications in international peer-reviewed journals and has authored 19 books. I think she is a regular fixture in all our conferences. She is omnipresent, omniscient, and we are really honored to have you here, ma'am. Our next expert faculty is Dr. Vivek Dave, one of the younger stars in vitreoretina in India. He is the head of the Anant Bajaj Retina Institute at LV Prasad, Hyderabad. He is an adjunct professor also at the University of Rochester, New York, USA. He's done his training in both AIMS and LVPI and has over 140 publications. He's also an LDP mentor at APAO. He serves as the editorial board member at very reputed international journals and has won the Young Researcher Award from VRSI. Dr. Ritika Makhija is the consultant ophthalmologist, cornea, cataract, and primary care at Sussex Eye Hospital NHS Trust, Brighton, UK. She's done her training from RP Center, AIMS, New Delhi, and she has 50 peer-reviewed publications and several book chapters. She is a author of a book, Corneal Infection and Inflammation, and has 70 plus presentations at national and international platforms. Dr. Rashmi, one of our debaters today, is a consultant cataract and refractive surgery at LV Prasad, Hyderabad, has done her training from JIPMER, NN, and has done a fellowship in the University of Nottingham as well. Has 30 publications, several book chapters, and has won several awards at IJO for best publications, has won travel grants, and has got best paper awards at national and international conferences. And last but not least, Dr. Prasanna Ramesh, our other debater today. He is the research director and glaucoma head at Mahatma Eye Hospital. I know him personally because we work with YOSI very closely. He's a joint secretary of YOSI. He's got 14 chapters, 52 PubMed indexed publications with NH index score of 10. He's the editorial board member of IJO and also a winner of several awards, too many to list. Some of them include the RN Singh Young Achiever Award and Yo of the Year, if I remember, last year. And we are honored to have you all, both as debaters and our expert faculty. So let's hand it over to Rolika now to take the meeting forward.
Yes, thank you, Dr. Apurva. Thank you for introducing everyone and welcoming us all. And thank you, everyone, for joining it. And before we start, just briefing you a little bit about the debate today. We start a debate between Dr. Rashmi and Dr. Prasanna. So the topic for today is the only way forward. So the topic states that RCT is better than a retrospective study. And we have Dr. Rashmi supporting the motion, and we have Dr. Prasanna against the motion. I'm sure that for both of them, it was a little difficult to even go with the motion and against the motion, and following which we will have discussion and rebuttal from the expert panelists. We keep the flow of this webinar absolutely on discussion base, not on lecture basis, because we want people to know exactly what the experts are thinking and what they've gone through and what they have faced. So the entire structure is based on that. So I request Dr. Rashmi to please proceed with the for motion of the debate. And
Thank-
it's going to be very timeline, so it's just 4 minutes for the debates.
Yeah,
Okay.
I'll try to stick on time. Is my screen
Yes.
visible? My slides are
Yes.
visible. Yeah?
Absolutely.
Okay, so I'm going to be talking for a randomized controlled trial in this particular on this particular topic. So why are we even debating this? Because study design is important, and why it is important is because it ensures validity and reliability of the study. Secondly, the study design should be such that there should be minimal bias and confounding variables should be taken care of. It helps in making informed clinical decision making, and of course, it is important in regulatory approvals and fundings. Sorry, let me just minimize this. Yeah. So what are the types of study designs that we are discussing today? One is the randomized control trial and another is a retrospective observational study. So in an RCT, the participants are randomly assigned to a treatment group and a control group to reduce the bias by making the groups as equal as possible in the patient characteristics that will have any impact on the outcome. So that is the purpose there. In retrospective observational studies, we are looking backwards. So we just observe the differences in the outcomes that occur after the treatment decisions have already been made without any regard to ensure that the patients in different arms may have different characteristics that are related to the outcomes. Sorry, yeah. So looking at this level of evidence pyramid, we know that randomized control trial are considered to be a high level, like almost level 1 with meta-analysis and systematic reviews. And why is that? So before understanding that, let's look at the key components of RCT. So in an RCT, you first thing you have is the randomization of the patients into a treatment group, and there should be a control group usually. Following this, there would be an intervention done, and the outcomes would be measured between the treatment arm that received the intervention and the control group that did not receive the intervention. So what are the advantages of this design is that it minimizes the bias and the confounding variables. It helps in establishing cause and effect relationships. It provides a very high quality evidence for decision making and allows for generalizability to broader population. And of course, it facilitates meta-analysis and systematic reviews, which are going to use the data from RCTs. And like I mentioned, they are also level 1 evidence in the pyramid. Now, looking at why retrospective studies might not be as good is because they will have different types of biases, and I've given some examples here. For example, sampling bias. To give an example, if there is a study on a new treatment, but it is including patients only who have completed the treatment, but patients might have dropped out and they are not being included. For example, this particular study on cross-linking in ultra-thin corneas, they have taken stromal thickness between 214 to 398 microns, and they've looked at it retrospectively and looked at patients who completed 1 year of follow-up. But there could be patients who dropped out or the cross-linking did not work and they required keratoplasty, etc., which were not taken into account. So that becomes a sampling bias. Second is because we are going backwards and the research question is formed later, there can be errors in collecting and recording data. For example, in this particular study on intracorneal ring segments, the authors have acknowledged that there was absence of measurements of biomechanical parameters, which may be important in this particular study of keratoconus, but that data was not available because they had done a backward look. And then there can be a confounding bias. For example, factors, these are the factors that affect the outcome and are also related to the exposure. For example, this particular study in Biju, which came on repeat cross-linking in failed primary cross-linking in keratoconus. And they said that younger age was associated with failure of primary CXL. But they did not have a control group to say that younger age was seen only in the failed CXLs and not in the stable group. So this could be a confounding bias because age is related to both. So the limitations in retrospective studies include lack of control, like I said, incomplete data can be there. Again, a temporal relationship is difficult to establish because the study can examine the relationship between risk factor and outcome, but it can be unclear which happened first. So it can be difficult that way because it has already happened. Then next is RCTs help in improving practices because like I said, there are no biases. So again, 2 landmark studies to give example. One was an RCT that showed that corneal cross-linking in progressive keratoconus works versus just observation. So they tried an intervention and they showed that it worked and that changed our practice in that. And the second RCT is in pediatric keratoconus where they showed that transepithelial versus the standard protocol the transepithelial does not work as well. So that also influenced our practice quite a bit. Then, like I mentioned, RCTs are required for regulatory approvals, such as this particular trial came about in 2016 and 17, and that is when the FDA gave approval for CXLs, which was much later than when the rest of the world was already doing the procedure. But this was a requirement to get the FDA approval in that particular state. And then, of course, like I said, RCTs are required for meta-analysis, which is the highest level of evidence as well. So to conclude, RCTs minimize bias and confounding variables, resulting in more robust data. It, like I said, helps to establish cause and effect relationships. It is also important for regulatory approvals and to facilitate meta-analysis and systematic reviews. And so currently RCTs are considered the gold standard in clinical research. Thank you.
Thank you so much. We'll take one quick comment from Dr. Namrata ma'am, and then we will go to Dr. Prasanna's debate. Namrata ma'am, what would you like to say in support of RCTs?
So I am biased right from the beginning for RCTs. The reason being that the data is prospective, although I know that there are limitations of RCT, and maybe that comment we can share after Dr. Prasanna Venkatesh's talk. But I feel RCTs, and I have done more than 40 RCTs. When you do a RCT, of course, your follow-up is very good, your patient inclusion is good, your randomization is good, you know what you're doing, you're following them up on various points, and you know what is happening. And if your power of the study is good, then it will really tell you whether this treatment modality is working or not working. Secondly, I think all the studies, which are retrospective in nature. And RCT, another advantage is, suppose you don't have a system of having a very good retrospective data, then you like to do randomized control trials, because you are studying a particular question, you follow it up, and you make sure that you have all the documentation correct. We at RP Center began to do our RCTs way back when Professor Vajpayee was there, mainly because of this reason, because the data at that time was not in EMR. So there was no way of, studying a question, because you had to pull out everything from all the machines and then put it together and collate it. The intranet, intra-hospital network was not there. So when you have to do that kind of a thing, when you're not too sure about the quality of your retrospective data, then I think it is best to do a randomized control study. For one, it gets published, even if it is a negative one. It doesn't matter if you have to say that this treatment doesn't work, then also the chances of publication are much higher with randomized control study. Two, it is actually making a difference to your clinical practice this way or that way. And three, the citations are always much more than for any of the retrospective studies. So people tend to quote it more in future.
We agree with you, ma'am. And I think that Dr. Prasanna is also nodding and he's just wondering what he's supposed to be against the motion for. But over to you.
In the beginning only, I wanted to say that for Rashmi, it is easy. For Prasanna, it is actually difficult. It's a difficult, challenge.
Yes, ma'am.
Yes. So over to you, Dr. Prasanna. I think let's see how you will make the difficult seem easy now.
Thank you, Rolika, for throwing me into the deep end. But let me see how I can, manage the screen sharing.
Yeah.
Thank you to the whole research matrix for the opportunity, and I'm just here to counter my counterpart with retrospective analysis. So as you know, it has case control, cohort, and database, with medical records being the databases being the one that we go to. And the past is what we are going back to rather than the future. And the disease will be traced back towards exposed or unexposed. And you can have, rare outcomes, or inference is quite moderate in this. And even if you have no diseases, again, you can still go back and trace the records. And the strongest point here is observational. The cross-sectional design has poor inference because it is only for descriptive purposes. It just states the problem. There is no direction at all. RCTs, as the previous speaker has exclusively told, we have the treatment group as well as the control group. And why not RCTs? It's expensive, time consuming. Maybe for somebody to start, it may cost, economics part plays a role. Rare diseases may be difficult. And just quoting a statement, sometimes it may take years. or even decades. So many cancer drug trials took over 10 years before approval, and non-representative populations can always be a challenge, like pregnant women, elderly population, to get consent, and those ethics approval takes a task. And sometimes when a pandemic hits the world, something like COVID-19, when you take an RCT, signs may take time because pandemic can happen at any moment of time. And here you can see that the wait, it's already over. So you have to just go with the historical data. Ethical issue with placebo use is something that is one. Cost and infrastructure, and RCTs are conducted in a controlled environment that may or may not reflect the real world environment. High dropout rates sometimes may serve as a factor. And yes, RCTs will start off great, but sometimes the dropouts again plan B, and sometimes, some people may rebrand it as a case report. Financial conflict of interest is another one. Pharmaceutical funding bias raises a question mark there. Publication bias, as ma'am told, definitely negative results can be published, but how many publications arrive? That is again another question mark. Self-reporting and data degrading, again, literature just shows this point as one concern. Ethical concern, limited generalizability because not everybody will have access. And can you deny a life-saving drug to a placebo group? And strict inclusion and exclusion criteria, does it reflect the real world? So again, another anime here to show it's just a confusion and worrying part here. And the strength of retrospective study here is fast, cost effective for somebody to start their journey, start like this, large sample size using real world data, rare diseases, it's very useful. Long-term follow-up because we are going back over decades, and ethically feasible, financially too. And some glaucoma drugs that if you see a review of literature, existing medical records through more light, and whereas RCTs again expensive and dropouts. Critics say retrospective studies have selection bias and confounding factors, but reality is the propensity score matching, multivariate regression analysis, and the big data and AI analysis. Because the propensity score matching helps you to match them better. The multivariate regression analysis adjusts for multiple factors at once, and the big data and AI helps you refine detecting hidden patterns in an RCT. So one path-breaking one was smoking causes lung cancer. Is one retrospective study by Doll and Hill, and also the COVID-19 vaccines and diabetes and cardiovascular risk issues that happens in a diabetic patient. So, but going forward, I feel we are going to discuss on this, how both can coexist with each other. And the statistical power is very important because large sample size increases the statistical power in retrospective, whereas RCTs will have to require good calculation for that, so that it is not well controlled and doesn't have a limited real world applicability. Combining maybe the way forward, like nested case control studies and pragmatic trials and real world evidences, for example, the use of EMR to validate findings. So, but to conclude, for the debate per se, these were my points. And also RCTs have high control, expensive, time consuming, ideal for intervention, and retrospective studies, quick, cost effective and practical. And I'm putting it slightly on top and for the debate, as well as RCTs are valuable for intervention testing, but retrospective studies goes back to real world scenarios with fewer resources, faster results, and for somebody to start their journey, I think that holds the key for them to start and then take it on forward. So thanks once again for this dynamic debate and the wonderful research team of YOSI for the opportunity. And thank you.
Thank you so much, Dr. Prasanna. I told you, right, that you will try your level best to make the reverse part of the debate easy with very valid points. Now the rebuttal discussion is open, and I request Dr. Vivek Dave to come up with some counter questions.
I'll just give my 2 cents on the two presentations. Rashmi and me hail from the same institute, but I tend to veer a bit towards retrospective studies. We've all been following the Champions Trophy, right? Currently. So I feel RCTs are the Virat Kohlis and Rohit Sharma. Everybody's talking about them. But if you read between the lines, I think we won because of Shreyas Iyer and KL Rahul. So those are the retrospective guys. In a nutshell, what I have understood, over my days in ophthalmology, is that RCTs are the backbone of regulatory approvals. You want an approval, you need an RCT. Otherwise, your thing is not going to hit the market. But observe the pattern of any new therapy that comes to market on the riding the horse of RCTs. Slowly, they start veering towards real world studies, because the entire gambit of RCT is in an absolute controlled atmosphere, I feel. Right? There are inclusion criteria, there are exclusion criteria. And I remember what one professor of mine used to say in MBBS: the patient who comes to you does not read the textbook. So the patient does not know that he has to fit into an exclusion criteria or fit into an inclusion criteria. So patients are going to come to us in all shapes and sizes. They are going to be compliant. They're not going to be compliant, take some therapy sometimes, not take some therapy sometimes. So I think a robust system where you have, say, a good EMR or a good documentation where you can enter maximum possible data, and then have a system where you can retrieve all that data, even though retrospective, even though considered as a lower rung of evidence, I feel that forms the major chunk of most of the evidence that we create nowadays, and major chunk of the evidence on which we work nowadays, right? Though RCTs have their prime role, I still feel it is the chunk of retrospective studies that really drives day-to-day science in the clinic. My 2 cents before we open up.
That was a very interesting analogy. First of all, I agree with Dr. Vivek sir about the cricket analogy. It was easier for everybody to understand the concept and importance of retrospective study. And in many of the institutes where getting an ethics approval is difficult, in even those institutes, I think because it's an exempt, it's easier and faster to do a retrospective study. But yes, it comes with its own, you know, parts of contraindication that Dr. Namrata ma'am explained to us. Namrata ma'am, would you like to rebuttal on that as well?
See, I would first congratulate Dr. Prasanna for his, very excellent. I didn't expect the presentation to be so good, frankly. You brought out all the right points, and I do completely agree. For rare diseases, you can't have RCT. For diseases like COVID, you can't wait for RCT. And for institutes where it is not possible to get that amount of funding, or where regulation is difficult, then RCT becomes a real challenge. So you cannot do it at all places. That I agree completely, but I still feel that if you have to say what is the benchmark, and what is that study, which will answer the question, I still believe it is randomized controlled trial. And having said this, most of the studies first are actually retrospective analysis, because even to calculate the sample size for a randomized control study, you need some baseline data, which probably comes from retrospective studies or from pilot studies, which are not randomized control trials. So I think both of them complement each other, because one is not the substitute of another. And two, because you need a sample size for a randomized controlled study to say what works and what doesn't. RCT only refines and redefines whatever uh, has been the outcome of a large retrospective analysis or a small retrospective analysis. To me, it is just like a step ladder thing, so you go from, just like you first do case letter to editor, and then you do case reports, then you do retrospective studies. So I think all of us who are into research will move the ladder up like that. And like I said, for everything, you don't have to do a RCT, but then uh, for certain things, for regulatories, they are required. For FDA, approvals, for CDSCO approvals, for approvals from DCGI, they perhaps are required. So sometimes they become necessary evils, especially when you have to market the drug or market the technique or market the technology. But at times, sometimes you cannot have RCTs. For instance, if you're reporting complications of phacoemulsification, or you can just have descriptive data, and you cannot have randomized control study, especially when a technique is fully established. After that, having, FICO is fully established, or anti-VEGFs are fully established, then it is not possible. And there are in industry, if you see, if you want to compare a drug, for instance, if you want to compare moxifloxacin, you tell Alcon, okay, I want to do or Novartis, that I want to do this study, and you say I want to compare it with Ketaflox and with cefazolin and tobramycin, they will never allow it. They will allow you to compare moxiflox with cefazolin and tobramycin, but they won't allow you to compare moxiflox with Getaflox with levoflox. So they will never allow you to do it. There, you would just have to do the comparison with a thing which is, gold standard, or which is not that commercial. So those kind of limitations, of course, RCT does have, where, you cannot do it in all the patients. And like I said, you can't afford it, or you have problems in obtaining the ethics approval. But I feel both of them complement each other. For this kind of diseases, you should do this. For rare diseases, you should bank upon retrospective analysis, etc., etc.
Thank you, ma'am. I actually had a few questions for debaters as well as panelists. So is it true that big grants like ICMR, they would prefer prospective studies and RCT over a retrospective analysis? Like, for example, if I want to do a large retrospective study, which is AI based and it will require resources and will have a budget of its own. So is it logical to apply for those prestigious big grants, or should we start with something small as a beginner?
This is for ICMR you're talking about? No,
Yeah,
there
like
won't. It depends on the topic. So if it is like artificial intelligence, AI, then AI is a big thing. And then AI, even if you have retrospective and images, it does well. I mean, they need a data base of images. So I don't think that will be a problem. They wouldn't want you to do it prospectively, because that will take a lot of time to get so many images, which you would be having in your data bank. So you don't need to actually do a prospective study, especially for AI.
okay. And also that if I'm a private practitioner, so can I also be an independent PI and file for those big grants, or do they prefer people who are in authority or are from institutes who are well established? Is
No,
it something?
private practitioner can do it. There is no problem. And ICMR has a centralized ethics committee where you can apply even if you don't have your own ethics committee. But most private organizations now do have their own ethics committee. They create one in case they don't have it also. So, and if you don't have it, then you can always apply to the ICMR ethics committee, which is centralized.
That's a cue for a new ethics committee coming up for Ayushi, right? She'll create one. And Dr. Ritika, what would be your perspective when you see a different research scenario in India and in UK? So what are your inputs on this?
So I think having worked in AIMS before and having participated in research there and here, the first thing I would say is that in many ways it's easier to do research in India. We have a lot of resources and there are less hurdles to jump in context of regulatory bodies and ethics. So here, even for a retrospective study, you have to submit for an ethical approval just in order to get the patient data. So I think that's something which I particularly found quite different when I started doing research here. But I think as long as, with regards to your previous questions, as long as one can justify the impact of the study, whatever the design may be, retrospective, and obviously you can justify why the funding is needed, I think it's all in the study proposal. And I think funding, because you can get travel grants for, so we had a similar, in response to your question, Ayushi, one of the registrars submitted a retrospective AI-based study and they received a European travel grant, research grant for the same. So it is very much possible, especially as Dr. Sharma said, that it's a very upcoming topic. So as long as you can justify the impact of your research, I don't think the design matters very much.
Right. So I agree with your point, and it's all about the getting the correct study design in place, and then everything eventually like rounds up and falls in place. And we do have a separate session. Is my screen visible?
Not
Not
yet. Not yet. Not yet.
Take some time.
Started screen sharing.
Getting there. Now is it okay?
No, we can't still see the
Now,
screen.
now we can.
It is seen now.
Now we can see.
Okay, perfect. So we are moving to the part which is the case scenarios. And I know that everybody is a little intrigued about what these case scenarios are going to be like. So we have tried not to tell everyone about the case scenarios. And so this is going to be one-on-one, like, one question per panelist. So the first one is for Dr. Namrata, ma'am. So it is safe to say that with your experience and you're an expert in handling fungal keratitis. Now, over time, you have tried different treatment protocols with multiple complications in your patients that you have treated. If you were to report the most appropriate and standardized treatment protocol for fungal keratitis, which one would you prefer? First option would be a retrospective study to see various combinations that you have attempted on your patients and then assess that which one worked out the best. Or you will conduct a prospective RCT with your two best management protocol options to conclude that which is the best treatment plan. So we know that, I think we kind of know your answer already. But what would you do in such a situation? Because you've treated so many patients in the past, that means you will have a very huge sample size. And then you have a forward RCT option as well.
So if you say talk about fungal keratitis, this is an easy question because I've already answered it and already published on it. What we now follow is the TST protocol, which is the topical, systemic, and the targeted therapy in fungal keratitis. Now, when the mycotic ulcer treatment trial 1 came, it looked at whether netamycin or whether voriconazole. So it solved the problem. It said netamycin was the first drug of choice. When mycotic ulcer treatment trial 2 came, it looked at the problem whether systemic should be given or not given. And it said that for fusarium, you can give systemic, but otherwise it doesn't work. So we at the same time were looking at intrastromal injections and were looking at intracameral injections. And as soon as I saw the structure of the mycotic ulcer treatment trial, netamycin versus voriconazole, I changed my clinical trial to intrastromal netamycin versus intrastromal voriconazole versus topical netamycin and voriconazole. And both the trials were designed at the same time. So just to say that when you're designing a trial, it is good to know what is already happening, and then you design your trial a little differently so that you don't duplicate what is already happening. So to say that we did do separate studies, we published one on intrastromal injections, then one on a drug that we were working on, netasol, and then netamycin. Netasol is soluble form of netamycin. And then third therapy would be, netamycin and voriconazole, which is a combination therapy. So we had separate publications of patients, and these were all randomized control trials. And we knew which one works for what indication. Now, our question when we designed this trial, that is the TST protocol, was what is the algorithm? When will you start the drug? When will you add the drug? Topical medication, another one. When will you add the systemic drug, whether voriconazole or ketoconazole? When will you give targeted therapy in the form of intracameral or intrastromal injections? So we then we prospectively recruited 223 patients, and then we looked at made a treatment algorithm, and we looked at how this treatment algorithm would fare for each of these treatment modalities. And we found that, we could treat with each of these treatment modalities if, we make an algorithm like topical netamycin first you give, and then if it doesn't work for 2 weeks, add topical voriconazole. If it doesn't work, you can add systemic, and you can give targeted intrastromal or intracameral depending on the lesion. So we looked at the whole follow-up picture and we formulated this algorithm. And because this was prospective, it was very well accepted. Of course, I do know that there are still some lacunae which are there, but like I said, continuity in research is very important. So if you're working on a thing, then you're working on a thing, and then you try to solve the answers, which are and give answers to all the questions, which are required to treat a particular modality. So my preferred protocol is still topical, systemic, and targeted therapy. And we've already done randomized control trials, but we've done in bits and pieces. We had to put it all together. So this is already published in Cornea.
Great, ma'am. Ma'am, congratulations on that paper, because the whole point of us asking this question was based on that paper, because it's important for people to know just not the outcomes of a paper, but the process that goes in doing the research as such. And so, ma'am, it is safe to say that a prospective way is the standard protocol, the gold standard, because that even sets a precedence and it also is more citable. But at the same time, you do need a combination of retrospective study analysis as well to look into the small segments of it, or to look into the rare complications, because of course we're not looking at the complications going forward. And so a blend of both and multiple studies are required especially when we are setting up, a treatment protocol which is going to be the standard, which is going to be followed worldwide. Thank you for that. Ayushi, over to you for the next one.
Yes, thank you, Rolika. I have a question for Dr. Vivek, and I think I also know the answer now. So, Dr. Vivek, you suppose you are requested to study and report the causes and outcomes of nucleus drop at LVPI. What would be your research design for the study? And especially considering that somebody else has already done a small retrospective study on that topic. And also, if I was your VR fellow, how would you go about training step by step for this?
Right, Arushi, thank you for the question. But no, thank you for not letting me know that this was the question before, though I asked you all a couple of times. Anyways, so I look at a study question in the way that, you sort of break it down. The first thing that comes to my mind is, okay, fine. We have to look at causes and outcomes of nucleus drop. So what is the event? The event is nucleus drop. All right. How common is the event? The event is not common. Right. It's not that every day a resident is going to do a nucleus drop. I mean, if that is happening, then he's soon going to be your ex-resident, right? So this is something that in my book is not something that you can pursue prospectively very well, because to get that number of cases to occur so that you can observationally study them and look at the causes and outcomes, it's going to take a lot of time. At the same time, if you are a big place, or even if you are a relatively small place, but if you have good data record system, a good system of really capturing each and everything that you capture about a particular study, you can look back at your data and look at the outcomes. You can get your incidence of the complication occurring. You can get the entire clinical scenario of your complication occurring. And the way I would look at this is, when you talk of causes, you just don't look at, say, for example, 75% of your nucleus drops were in males and 25% were in females. So does it mean that males are at a greater risk of nucleus drop? No. This is just a demographic parameter. So whenever you have a rare thing, you look at it retrospectively. Then you look at all potential factors that you think in your clinical understanding that may affect the outcome. All right. Gender really does not appeal. Be it a male eye, be it a female eye, doesn't mean it would be highly prone to a nucleus drop. So what about age? Yes, age would matter, because with age, the hardness of nucleus matter changes. With age, the compliance of the patient to the surgery might change. The way you operate might change. So age becomes a factor. Type of cataract becomes a factor. The type of surgery that was being done becomes a factor. The seniority of the person who was operating becomes a factor. So what you do is you list out all those particular clinical factors that you think can cause this problem. Then in your data set, you also look at the other arm where this nucleus drop did not happen. The number of events that you had of the nucleus drop happening, take a comparable or 2 times control arm from where the nucleus drop did not happen in your retrospective data. And now put all of these things into a good logistic regression system. So logistic regression or regression analysis is one of the strongest and most powerful tools that you can use in a retrospective study, which gives you that additional punch above and over just presenting demographics. That my case of 50 eyes was 40 females, 10 males, average age was so and so. This is all demographics. But once you put this into a logistic regression analysis software, where you flag your adverse outcome as nucleus drop and a good outcome as an uneventful surgery. And then, like I told you, put all potential factors that you think may be affecting the outcome. The final outcome will tell you not just the incidence of your occurrence, but will also tell you which amongst these factors which you put in had the biggest bearing on the outcome, right? So an important thing to understand here is the software is not a magician. The software will not tell you what affects. The software will only tell you whatever factors you have put in, and those you have put in from your clinical intuition. So the first and foremost thing is your clinical understanding of that situation, which makes you think which factors potentially could be the affected reason or could be the predisposing factors. Those, when you put into the software, it will give you a final analysis of the strength of association of your adverse outcome with a particular risk factor, and that the software puts across in the form of an odds ratio. So the odds of me getting a nucleus drop if the patient has posterior polar is, or the odds of me getting a nucleus drop in a patient who is more than X years of age is. So how does this make you wiser? This makes you wiser that next time in your clinic, you see a patient with any of these factors, you tell yourself, okay, fine. As compared to a normal person in the population on the street, this particular eye is X time more predisposed to a nucleus drop. Hence, I need to be that much more extra careful. So in a nutshell, because a relatively rare event, I would look retrospective. I would dig into a good system of record keeping, pull out data, sieve out all the data which is not clean, take all that clean data, arrange all the risk factors that come to my mind, and they have to appeal to me clinically, put them all into a logistic regression analysis software. Logistic regression, so your outcome is dichotomous. It is, yes or no sort of a data. And then that gives you most, or the best potential research design for this particular question.
Thank you, Dr. Vik. That was very insightful. And since you talked about the software, I wanted to ask you if there are any free softwares available for doing a regression analysis.
I use MedCal. I purchased it for 22,000. I don't know if there is a crack available somewhere, but even if you spend, I think it's a good one for us clinicians. I don't have loads of publications, but I have 160, and I can tell you I have not gone to a statistician ever in my life. The last time I went to a statistician was my RPC thesis. I've never gone to a statistician after that. That MedCal actually gives you examples which are inbuilt into the software. So when you click on any particular test, it will give you a big explanation of how the test works and what sort of a data it takes in. And it's pretty intuitive. You can just play around and understand. Otherwise, the other standard ones are SPSS and Strata. I personally have found them to be a little more tedious. MedCal works really well in my hands. Another follower of MedCal is Sayan Basu. So I think that approves the choice.
And I do agree with this point, Dr. Dave, that it's important for us to do our own analysis, because a statistician might just give you more over the numbers. But while you're doing analysis, you can actually play around with different combinations, and that gives a stronger result output. So I think it's highly suggested for all the researchers to proceed with reading a little bit more about biostatistics. It's very helpful. I completely agree. And next, I request Anujit to please go ahead and take the third scenario for Dr. Ritika Mukhija.
Thank you so much, ma'am.
Did it move? Yes.
Yes. So my question for ma'am is that you witnessed a rare case of an orbital tumor with unusual presentation during childhood, occurring now in a man in his mid-40s. So the first question is, what would you do in such a case? Your options are, would you report it as an isolated case report? Would you retrospectively assess all historical cases and see if there are more cases in the center in the past and make a case series on the same? Or would you conduct a multi-center analysis and gather greater amount of patients to increase the value of the study?
Okay. Thank you, Dr. Anujit, for this scenario. So I think we haven't spoken about case reports and case series so far, and from what we've discussed, they are sort of at the bottom of the pyramid of evidence-based medicine. But this is a very useful scenario to indicate that they have a place of their own in research and evidence-based medicine. Now, taking this particular scenario as an example, if I saw a rare case of an orbital tumor, which usually presents in childhood in an adult patient, I think there were two things that I would do initially. I would speak to my peers and more senior colleagues with more experience as to get a general idea of, is this something that they have seen before? Because that would give me an idea of how much effort I would put in to try and retrospectively get more data about that from the center. And I would do a quick literature review to see what's been there. I think options 1 and 2 could sort of go in the same category, whereas option 3, whether to conduct a multi-center analysis, will be a different game altogether. So if it's a very rare case, very sparingly reported, I don't think doing a multi-center analysis and trying to get lots of patients will eventually add a lot of value to the study question. Because doing a multi-center analysis takes effort, takes time, takes a lot of coordination, and you have to determine what the study question is that you're trying to answer. So the first thing to understand is, when would you like to report a case as a case report? So it might be a rare presentation of a common disease, which is possibly what this scenario is reflecting towards, or it might be a complication of a known modality of treatment which has not been reported, or it could just be a learning message or a teaching message for a very common disease. If you can identify more similar cases in your center and you can make a case series, that definitely has more value as compared to a case report, because case reports you cannot generalize, whereas if you find a similar pattern or a trend, that is something that can be generalized and that has a better teaching message. But a multi-center analysis for a rare case, in my personal opinion, I think it's being pragmatic. You'll probably be using a lot of your effort and time for something that may not particularly enhance the answer to that research question.
Right, ma'am.
So,
So
sorry, go ahead.
I'll just add one additional question. So let's say in scenario number 2, you do find that historically there have been one-off cases, maybe separated by ethnicity or of some other kind. So what would be your clinching criteria for actually not going for a case series in that case and going for a multicentric analysis? Suppose you do find that there are one-off cases, maybe over the last 7 years, there have been maybe 3 to 5 to 7 that has been reported. So would you wait and keep collecting the data for 1 or 2 years and see if you find something like this, or would you just let it go? And what would be your suggestion be?
That's a very good question, and I think slightly difficult to answer because there's no clear yes or no answer to it. Now, if I find that there are more cases, and if I find a pattern, I think certainly it makes sense to collect the data and just present as a descriptive analysis, even if you can't do any particular statistical analysis on that. I think that's definitely useful for publication, and that might have more of a value. But if I feel that this case is something unusual, it hasn't been reported much in literature, I won't wait trying for more cases to come in order to publish that. I think in that situation, it might be better to just go for an isolated case report.
Right.
Right.
Dr. Ritika, you mentioned that case reports and case scenarios, case series would be the bottom of the pyramid. But I believe that they're actually the first things that come to anybody to start off with. So they should technically be top of the pyramid in terms of understanding research to go forward. It's the first step to it. And I must appreciate that I have seen that in your publications, you have actually used this concept. You have seen something, promptly report it, and that's exactly where the question comes from.
Yes,
So, on your
so
report.
I did think of that. So yes, we when I was in RPC, we saw a rare case which we thought was amelanotic melanoma in a 35-year-old male, I think, but that turned out to be a retinoblastoma. And it wasn't that it wasn't reported in literature, but the way it presented was slightly different, and there was a good clinical message there. So we went ahead and published it as a case report. But I would mention that I did check with pathology to try and find out if we had a lot of adult onset retinoblastoma cases. But the entire process was not very easy. So pragmatically speaking, I think you have to see what is the ease of data collection if you want to make a case series. And sometimes if the level of input that is required is more, you might just stick to the case report. Now, coming back to your point, that's a very, very important point. And I think most of us will agree that probably the first publication we had was a case report. And I think it's a very important way. It's sort of like the gateway to the world of research, especially when you're training. It's a very useful exercise because you do literature review, and then you get used to how you scientifically write a case, which is quite difficult to how you clinically present it. And often, case report gives you a research question, which you may or may not be able to further build upon into a proper study. So while it is the bottom of the pyramid in terms of evidence-based medicine, in the sense that you cannot generalize your treatment or management of a disease based on a case report, I think it has a place of its own in medical knowledge, and it adds to the overall body of medical knowledge about any condition, but particularly rare conditions and rare presentations.
Right. Thank you, Dr. Ritika, for the publications and for your inputs here. I request Nandita to go ahead and take the question for Dr. Rashmi.
Thank you, Dr. Rolika, ma'am. My case scenario is for Dr. Rashmi Desno. Which is the best study design to conduct a multi-center study on a novel surgical technique being used in multiple centers randomly over last 3 years with different protocols?
Hello. Hi, Nandita. Thank you for the scenario. So, what I'm catching here is what is the best study design? We want to conduct a multi-center study on a novel surgical technique. So, like I was speaking for RCTs, I would kind of go towards that a little bit because we are saying that it is a novel surgical technique. So, I'm assuming that there would be one arm where you want to do the surgical technique, and you would have a control arm where to see whether the surgical technique is actually beneficial or not beneficial. It could be observational arm. It could be something which was a standard protocol, so like a surgical technique which is already in use and is established technique. That could be one of the arms. And that is how I would actually go about if it is a multi-center study. Because when you are looking at multiple centers, you're also looking at different kind of populations or the environments, and that is where you need to standardize things also. So your inclusion criteria, your exclusion criteria, and the rest of the biases which need to be taken into account need to be standardized throughout the centers. And that is why I would err towards randomization and of course a prospective study with multiple arms or at least two arms to compare the results between the novel technique that we are trying to do and a standardized technique or a purely observation and no intervention arm, and then comparing them to. Then the next part is that these multiple centers are doing the surgical techniques randomly with different protocols. So that also needs to be standardized across the centers. And then you would probably compare the surgical technique with the traditional treatment is what I would say in this particular scenario.
Right. And how easy will it be to iron out the concept of ethics in different centers? Because here you will be taking in ethics approval from multiple centers, and it's going to take so much time. So what do you think about that? Every country will have different policies. And I'm probably looking at multiple centers from different countries as well.
Yeah.
So
So it can be multiple centers from the same country. It can be multiple centers from different countries. When there are multiple centers from different countries, of course, it becomes difficult because the regulatory approvals, especially when you are using tissues or new kinds of drugs, are different in different kinds of in different nations. Like Dr. Ritika was mentioning, it would be probably much more difficult in Europe as compared to when you are doing it in India, getting the ethics approval, and that does play a role. So it can be quite challenging when you are actually dealing with centers in multiple nations, and that is the other challenge there is that the population that you're dealing with is also very different. So these
right.
do take time, and it takes time to iron out, especially making sure that the conditions are the same, the population is more or less comparable, the technique used is the same, so the equipments need to be similar that they are using, instruments need to be similar, and the investigation techniques that you're using to measure your outcome also needs to be similar. So this does take a little while to do that when we are talking about a novel technique.
And as Namrata ma'am said, that if you're doing that, technically you're getting a more authentic outcome. And when the results come out, it has more weightage and more value. So we must remember that pearl, that if you do in our city, prospective, multi-center, that's even stronger.
Yeah,
Right?
and this I would say because we are talking about a new surgical technique here and we are trying to establish that this surgical technique works or doesn't work. So that is
Correct.
where it would matter.
We'll take one brief question for Dr. Prasanna by Anujit. So over to you, Anujit.
Thank you, ma'am. Prasanna sir, this question is for you. So this is the fifth scenario where you are asked to compare drug X, which is a new drug, with a standard established drug Y for a disease, for example, ABC disease. So how will you conduct a superiority versus non-inferiority trial? Also, if drug X develops a serious side effect amidst the research, what will you do? And what would be the next course of action in this study?
So as I spoke about combining, I think this is more like an RCT question. So I did think about combining retrospective and prospective approaches as well. So if at all, when I'm comparing two drugs, and if it's a novel drug that I'm asked to compare, and there is no previous data, superiority versus inferiority trials, if possible, multicentric would be again the way forward, and keeping RCTs again in mind for answering this question. So if possible of an hybrid design, if it is not a novel drug or if something that is already there, I would always go back to an hybrid design and analyze what has actually happened retrospective as well. But if it's a novel drug, then, when there is a serious side effect that is detecting among research, which I covered as a downside of RCT, keeping the ethics in mind, the ethical point of, I need to report it because though we had got an ethics committee approval, that is what we all do when we do an RCT. But keeping that in mind in study when it is going through, definitely reporting it is one that is very important. And if not, even pausing it or stopping the arm if it's a serious side effect. So what would be the next course of action? So there are two drugs, right? And you are telling that drug X is having an issue. So the other course of action is if at all you are able to continue the study with drug Y. For example, since we had retrospective and prospective, many a times for PGs or residents, when we give a thesis, we don't give them a retrospective study. We give them a prospective study because at least I would want them to know how to interact with patients, collect data, and take it forward. So at least let us see how we can have, the efficacy factor or how is the at least one drug that is actually doing in case of the other drug that has been pulled out because of the serious side effect. So yeah, I think that's all about it. Keeping
Yes, sir.
in mind, I'll give it to
If I,
Rotika and not use the
Right.
6 minutes.
if I may just pitch in here,
Yeah.
Yes,
just
ma'am.
to give you one example, they tried to compare collagen cross-linking in fungal keratitis, and they found that the energy levels that they were using, and this was again Arvind Eye Hospital, and this was published in American Journal of Ophthalmology. That didn't work. So they aborted the study in between and just published the results of those 20 cases and said that it's not working. There are more perforations with it. And then subsequently, now they plan another study with a lower energy for microbial keratitis. So I think whenever a new drug comes, it's best to do a non-inferiority trial first. You just want to know whether that drug is working, not doing any harm to the patient. So you do first a non-inferiority trial for which the sample size also would be less as compared to if you plan a superiority trial. Then a serious side effect, then you have to abort the study and you have to, of course, report to your ethics committee. So this was just example, of how the study was stopped in between.
Right. Thank you, ma'am. I think those inputs were very important. And Vivek sir, I think you've raised your hand. Please go
If there
ahead.
is time, I don't know. Do we have time for 30
We
seconds?
we're just done with the time, but I think the conversation is going pretty great. So go ahead, sir.
Okay, I just want to simplify the meaning of superiority versus non-inferiority for the audience if the people are logged in.
Yes, sir.
In absolute simplistic terms, a non-inferiority means I have brought in a new thing. It is at least as good as, or it is not bad than what you know. And superiority means what I have brought to the table is better than what you have. So when do you use non-inferiority? You use non-inferiority anytime and always when you have a standard therapy and you are comparing a new therapy. Because the non-inferiority sample size will always be lesser than the superiority trial sample size. This is default math. So you will have to work with lesser number of patients in a non-inferiority trial because you only want to show that it is as good as or it is not inferior to what is standard. All right. If you go for a superiority trial, you require more number of patients. So that is why most people will do a non-inferiority trial. Second is most trials nowadays there is already a standard therapy and you are comparing a new therapy. So non-inferiority works. When do you necessarily require a superiority? When you have drug compared to placebo or vehicle. So if there is placebo or vehicle, you cannot have a drug which is non-inferior. That means it is not working. So in those scenarios, you always require a superiority trial. So it depends on what you are working with. That is the way in which you will choose which design you want to implement. And serious side effects are usually always taken care of in these trials because they will have classically what is called as a rescue arm. So if something goes wrong, this is the therapy that will be given. Or if something goes wrong in the experimental arm, that patient will be picked up and will either be taken out of the study or will be shifted to the standard therapy that is known. So these are a few general standard things that always work in non-inferiority and superiority trials. Thank you.
So,
for
Dr.
taking
Vivek, do we include those patients in our analysis for efficacy of that drug? The ones who have developed side effect, then we are now giving them standard therapy, but they were like on the way of treatment. They did not finish the treatment.
So those who do not finish the treatment ideally are dropped out because they have not completed the protocol. But then there is something called as an intent to treat analysis. So you define your protocol initially saying that you will include all of those patients who even undergo temporary or a partial follow-up or partial therapy, and then at least include their visits till the analysis of that particular visit for all patients. So if it's an intent to treat analysis, yes, you will. Otherwise, you will drop it. That again is a different discussion.
Okay. All right. So thank you so much for all the scientific pearls and the inputs. I think this entire discussion made a lot of questions answered on the Zoom platform, and a lot of people have confusions about which design to pick, which is superior, which is the better way to go. I think Nandita is also agreeing because it clarifies a lot of questions that she had in her mind as well. So thank you everyone for taking time out and coming for this discussion-based webinar and not just a lecture-based webinar. And thank you, everyone. And I think, Anujit, you can do the picture thing that everybody usually does before we sign out.
Oh, yeah.
And
So with pleasure. Ma'am, can you just unshare your screen so that I can
Oh,
get it?
sorry, it's my share. Okay.
All right.
Sorry,
So,
you're genius. Yeah.
so
Perfect.
just put the YOSI sign if that's okay with everyone. All right. So 3, 2, 1. Right. I got it.
Okay, perfect. Thank you. Thank you everyone for joining, and thank you Manjula ji for the technical support.
Thank you
And
so
Thank
much.
you.
Thank
Thank
you.
you. Good
Thank
night.
you.
Thank you so much, ma'am.
Bye-bye.
Nice
bye.
to see you, Ritika.
Nice
After
to see you, ma'am, and
longer
everyone else.
and Vivek first, but somehow I don't see, but I feel Vivek is closer than you because he's
Thank
in
you.
India. Okay. And nice to
Thank
see
you,
you,
ma'am.
Mr. Rolika. Are you back?
No, ma'am. I'll be back soon. Yes, ma'am.
Bye.
Okay.
Thank
See
you.
you. See you everyone in 3 weeks.
Good night, ma'am. Good night.
Good night, everyone.
Bye.
Bye.
Dr. Nandita, good morning.